Welcome to Inside ProMedica, your path to wellness. Brought to you by ProMedica Charles and Virginia Hickman Hospital, where your health is our mission. Each month, we bring you insights from leading medical experts, the latest advancements in care, and essential health tips to keep you and your family well. Let's get started.
This is Kathy Williams, and with me on tonight's program is Dr. Geva. And Dr. Geva, how long have you been with ProMedica?
Coming up on 3 years now.
Okay. So fairly new to the area. Are you mostly at Hickman Hospital, or are you at one of the other? Are you a traveler?
Yep, I split my time. I operate at Hickman, down in Toledo, and Defiance sometimes.
Okay.
Wherever I'm needed.
There you go. Well, we're going to be talking about GERD, which, probably throws people, but, heartburn and reflux and all that good stuff, and that's kind of your specialty.
Yep.
So help us understand, how does this all happen? A lot of us are popping antacids like they're candy. What's causing it? What can we do about it?
So there's a number of things that can cause reflux. Every one of us has felt reflux at some point or another. You eat too much, you get that weird burning sensation, or you lay down a little too early after a meal. When it becomes a problem is when you're reaching for those antacids more often than not. And the reason can be because either that connection between your esophagus and stomach is a little weak. We have a valve there, and if it's not working well enough, then you're going to get acid coming back up. Mm-hmm. Sometimes you can have what's called a hiatal hernia, meaning some of your stomach is sitting up above your diaphragm, and that's making it a little bit hard for the acid to stay where you want it to. And then there's any other number of possible causes for this.
So over the counter, if you find yourself hooked on over-the-counter meds, you probably should see a doctor.
Absolutely.
I would say.
And even if you've been prescribed them and you've been taking them for years, there's two groups of people that we tend to think of that might benefit from surgery where medications may fail.
Okay.
You've got the group who are taking it every single day religiously and they're still having symptoms and breakthrough reflux. And then you've got people who are maybe on the younger end, 20, 30 years old. They're already taking high doses of these medications and they're asking themselves, do I really want to be taking this 40, 50, 60 years down the line? I don't necessarily know what the effects are going to be. Maybe there's something else I can do.
Right. So help us understand, what are the newest procedures then that are available for dealing with these issues besides just taking pills a couple times a day?
So the most common procedure we do is what's called a fundoplication. That's where we take the top portion of the stomach and we wrap it around the bottom of the esophagus to bolster that area, to make it a little bit harder for that acid to come back up. There are some people who are doing these through endoscopy, what we would call a TIF procedure.
Okay.
And then there are a couple of other variations down there where you bypass that acid-producing portion of the stomach.
So are those fairly simple procedures? Are those something that you do, or you have to refer it to a higher-up surgeon?
Those are things that I do.
Okay.
That is my specialty. I'm fellowship trained in upper GI, MIS, and bariatrics. So that is within my wheelhouse and my passionate area.
So you brought up hiatal hernias. So how do you know if those are getting worse? If you know you have one, how do you tell if it's getting worse?
Depends on the symptoms. And the workup is just as important as the procedure itself.
Okay.
These procedures are incredibly effective when you do them for the right reason.
Gotcha.
So part of what we do is that, initial workup, getting the imaging, getting the endoscopy done, helping to figure out, are your symptoms really because of that hernia or because of reflux disease? Is there something else that's doing them? Because if there is something else, maybe we need to approach it differently. But if it is reflux, surgery may be a fantastic option.
Right. And are those fairly non-invasive then, or?
Minimally invasive.
Okay.
So the way that I do mine is 5 small incisions. Sometimes you can go home the same day. Most people stay for a night just to make sure pain's okay, nausea's all right, they're feeling well. But 98% of people are out the next day.
Right. So are there certain things that maybe we should eliminate from our diets if we're having trouble with heartburn, aside from
lifestyle
super hot sauce?
Lifestyle modification is a very important part of it.
Right.
Hot sauce definitely would flare things up. Highly acidic foods like tomatoes, ketchup, things along those lines. Mm-hmm. Chocolate, believe it or not, as much as we love it, it does flare that up. Caffeine, smoking.
You're ruining a lot of our lives right now.
I do get that a lot, unfortunately.
I would imagine you do. Are there certain things that we can do aside from taking antacids that might help? Are there certain foods that might help, or
Not
other
per
things
se.
to coat your stomach?
Not per se. There are
Okay.
a variety of medications that can ease things. And
Okay.
depending on how things have gone, if you've developed ulcers, there may be certain medications that would help coat that and alleviate it. But ultimately, like I said, diet changes, not eating within 4 hours of when you're planning on going to sleep, cutting out certain things like tobacco products.
Right. So there are some new procedures then. You kind of went over a little bit of those, but what can a patient realistically expect if they have anti-reflux surgery?
So again, if the reflux is caused by GERD or a hiatal hernia, the results tend to be excellent. It's not something we would do lightly. We want to make sure we're doing it for the right reasons, but you can get excellent long-term relief for years on years. A lot of patients come off of their medications entirely, but it is surgery. Surgery comes with its own risks. Anytime I stab you, there's going to be a risk for bleeding, infections, and damaging stuff around where I'm working.
Right.
More specific to these procedures, in the first couple of weeks to months, we look at dysphagia or difficulty swallowing. And so you're going to be getting used to what it is you can and can't get through there. You're going to have some inflammation and swelling from surgery itself.
Right.
There's a very specific diet we follow for the first month and a half, 2 months, just to kind of help ease into it. And then the next thing that we see after that swallowing issue kind of gets pushed back is what we'd call gas bloat syndrome. You may be swallowing a lot of air as you're eating. You've got some eating habits you've kept for 50, 60 years.
Right.
You're going to need to figure out how to eat a little bit differently so you're not getting all that air in there, because that air is not going to come back up on you. We've made it harder for things to lift up, so you can't burp as well. You're going to feel bloated. You're going to have a lot more flatulence.
Okay.
These will go away over time as you kind of figure out how to work around this.
Oh, wow. So the diet modifications ahead of time are just as important as the diet changes you're going to have to do after
Exactly.
the procedures are done. How does this affected with like gastric bypass surgery and things like that? Does that come into play with this?
An excellent question. Obesity is one of the bigger things that will lead to reflux disease. The more pressure we have, especially if we've got a lot of weight around the middle, we're increasing the pressure inside our belly, which is forcing that acid up into our chest. And so some people think these are two separate conditions. I have to treat them separately. A lot of the time you can combine the treatment and do it all in one.
Okay.
And as a bariatric surgeon, that is one of those things we look at. Every patient who comes in, I'm going to be asking them about reflux, because if you've got really bad reflux, a sleeve gastrectomy may not be the right way to go. A gastric bypass is probably better. You're bypassing where the majority of acid is made.
Okay.
In fact, that was the real reason we made that procedure in the first place, was because people were having bad ulcers, heartburn, things like that.
Right.
And like some of the medications we know on the market for other issues, we found this lovely side effect where we go, oh, check it out. These guys are losing weight. Maybe we can kind of steer into that a little bit.
Okay.
So that's where a bypass comes in for somebody who's got really bad reflux as well as obesity.
So the GLP-1s are, I guess, what's your advice as far as taking the weight off? Well, if you have a severe enough case, you may have already caused damage that's only repairable through surgery?
It can be that way sometimes. You brought up GLP-1s. They're great for weight loss. They're not as good as surgery, but they are a viable option. The problem with them, as we see, is they will slow down the amount at which your stomach is emptying. So normally, if I eat X amount, I'm expecting most of it to be gone within 4 hours.
Right.
One of the side effects of these medications is they can slow that down, and that can increase the amount of heartburn and reflux you're getting sometimes, or that feeling of fullness or stuckness.
Okay.
So it is a very personal thing. It depends on the patient. Some patients do great with medications. Some patients do great with surgery. And some people are in the middle of the road and can go either way.
Now, the bypass, though, is completely different than a sleeve as far as...
Correct, as far as the way that the anatomy lays out.
Okay.
So when we do a sleeve, we're removing about 70 to 80% of the stomach.
Okay.
And by removing that fundus, which is that bit that we wrap around for a reflux procedure, there's a number of hormonal changes that occur in the brain and the gut that drive down hunger and drive up the rate at which our body is burning energy.
Oh, okay.
With a bypass, we're making a small pouch out of the upper portion of the stomach and bringing up a loop of small bowel to that. So we are avoiding the majority of the stomach, the first portion of small bowel, and about another 2 feet after that.
Well, I find this all fascinating. So hopefully our listeners will as well. Doctor, how easy is it to get a hold of you, or Dr. Geva, how did they find you?
You can search for us online. So just look up my name.
GEVA.
GEVA ProMedica. That'll get you our numbers. Okay. I have a general surgery office, which is where I would do most of the purely upper GI stuff like anti-reflux procedures. Mm-hmm. If you are thinking about weight loss surgery, we do have a bariatric office in town as well. Okay. I'm there twice a month. We can do all the work up here, short of the procedure itself. We do that down in Toledo just because we've got the nursing staff for it there.
Right, exactly. Well, we appreciate your time.
Yeah, absolutely.
Learned a lot.
Thank you for having me.
Hopefully people will get in touch with you.
Yeah, looking forward to it.
That's it for this edition of Inside ProMedica, your path to wellness. We hope you've gained valuable insight into the exceptional care and services available at ProMedica Charleston, Virginia Hickman Hospital. For more information or to connect with our healthcare team, visit promedica.org/Hickman. Take care, stay well, and join us again on the last Tuesday of each month at 6:20 p.m. for another edition of Inside ProMedica, your path to wellness. You can also listen to these programs as podcasts anytime under the On-Air Audio tab at WLEN.com.